presentation. Because of time limit, I don't think we can allow any questions, so we have to move on to the last speaker. Thank you, Kim. Our last speaker is Dr. Abhishek Andaskar. So he is the founder and director of the Indian Center for Endometriosis and the honorary consultant and fellowship program coordinator in the MIGS and MGM Medical College in Mumbai. He is the panel faculty of different countries in Mumbai, Germany, Egypt, and Taiwan. So for that, I want to ask Dr. Monashi to talk on the 10-step LTH knife and fork technique.
Okay. Good morning. Thank you for the introduction. I know the chairpersons very well, especially Dr. Prashant and I go way back. We met in the 80s. And we're going to come to a very basic topic. Total laparoscopic hysterectomy and the knife and fork technique. And I say a knife and fork technique because we use reusable instruments. It teaches you to use both your hands. And the TLH is an interesting procedure because it's the gold standard of a laparoscopic procedure for gynecology. It is the most reproducible, the easiest to teach. It takes a minute to learn, but it takes a lifetime to master because as you continue, there's always something new to learn, nuances along the way. So the objective of my talk is to elucidate how to do a fast and efficient hysterectomy with minimal instrumentation. I'm saying fast, not by doing quick, rash movements. You achieve speed in laparoscopy by minimizing your bleeding, sticking very closely to anatomical surgical planes, and not using suction irrigation. So that's how you increase your speed by not changing instruments. I'll show you through the steps. I use about 3 instruments till the hysterectomy is complete, just interchanging the ports. So instrumentation, work in many hospitals. I use basic instrumentation, reusable, bipolar and scissors. And of course, there is many new technologies along the way that come along. And industry will tell you that you will save time using a harmonic or a ligature or whatever you have. But they will always compare to the bipolar. And I'm a big fan of technology. I use all advanced energies, but for different uses. So I love the harmonic if I'm shaving a nodule of the rectum in an endometriosis case, and the ligature if you're dissecting the bowel for a dissection. But for a basic case and to teach, you have to teach your fellows or your residents to use both their hands. So the bipolar and the scissors is the way to go. So as I said, all advanced energy that comes out is going to compare itself to the bipolar, which is the gold standard. It's the most cost effective because it's reusable, unless you don't know how to use your energy and you keep damaging your forceps, then it becomes expensive. It teaches you to use both your hands and efficiency. So beware of industrial propaganda, okay? So there is a use for advanced energy, but for basic surgeries, you do not bring a gun to a boxing match, you use your fists, both of them, okay? So this was a wonderful paper that came out of America, as Americans usually have time to publish things like this, and it was randomizing the ligature on one side and a bipolar on the other side and randomizing it between attending physician and resident. And they found that they saved 6 minutes per case at a cost of $254 per case. I don't know how they reached the calculation of their operating room time was $94 per minute. That seems a little expensive, especially where I come from. And so this is much ado about nothing. You have these papers coming out, they don't really mean anything, and in reality, 6 minutes is not going to make a big change to your life or your patient's life. Okay, so there's 10 steps to the perfect TLH. This is not necessary to follow in this order. Just in our YouTube generation, 10 steps is a cool way to remember things. So that's why I made this talk. Okay, so first is patient position and port placement. This is the basics. If you mess this up, you're going to suffer for the rest of the case. Then you try and manipulate it to make your life easier. Sectioning and cutting the round ligaments, division of the tube and the uteral air and ligaments, developing the bladder space, approaching the uterine vessels, colpotomy, specimen retrieval, vault closure, hemostasis, and lavage. You have to do that as the last step. Make sure you don't have bleeding so you can go to sleep peacefully at night. So patient position is important. I like to have the arms tucked by the sides, and there's no flexion of the hip joint with a slight flexion of the knee joint. Port placement, I use an optical entry through the umbilicus, the Lee-Wang point for larger utra or scarred abdomen. For TLH, I like to use an ipsilateral port placement because it makes my suturing easier. I will use a midline infra-umbilical port for DIE to dissect deeper down into the pelvis. For my right hand, I like to come a little more medial. Dr. Prashant and I have different viewpoints on that, but that makes interesting OR discussions. Coming to uterine manipulation. This is not a uterine manipulator, this is a myoma screw. It's for screwing into a fibroid. A lot of people in my country use this because they don't like to use your vaginal assistant. We have 1.6 billion people and growing. We have no shortage of people in the OR, okay, when we operate. And I need my assistant to assist me, not just hold the camera. My assistant is a very accomplished surgeon in most cases, so I have no complaints there, right? So speaking of uterine manipulators, the literature is hard to find. This was one of the papers by Janssen et al. In the Netherlands. They compared, this was a comprehensive review of most manipulators available on the market, and they found the Mangeshika manipulator and the Clermont-Ferrand to be the top of the list. The Mangeshika scoring over the other one because it allows you to levo and dextro rotate the uterus. And they said in case of endometriosis with the cul-de-sac, they may be the instruments of choice. I disagree. I prefer to use a Tintara. Well, actually, I don't like to use a manipulator for endometriosis. I will antero-fix the uterus to the anterior abdominal wall because I like to do a pelvic exam during my surgery to continuously reassess the nodule. Of course, if you're accompanying it with a hysterectomy, then you use a combination of both. Now, coming to the manipulator, it pushes Kiefer and then towards the right, which produces round ligament stretch. I approach with my bipolar in my left hand from the left lower portal, and I open in the space in this gray area between the IP and the external iliac vessels, and don't coagulate too close to the uterus. I will, just to take care of any retrograde bleeding, but I do not cut that. So the more you put this on stretch, the more space you get. Of course, in larger uteri, you might have to go a little more lateral. So don't cut more than you coagulate, and your bipolar is always at the ready to catch any aberrant bleeders. So you see, most surgeons are very anal about not allowing even the capillaries to bleed. So I try to replicate that through most of the surgery. I don't allow bleeding, so I don't have to use suction. This is an important step. You can see the assistant holds the cut end and pulls down. So this highlights the road you've got to traverse during the rest of the procedure. And just use the bipolar as a good dissector. Now, on the other side, a lot of people will reach across with their right hand, but I like to give it to my co-surgeon so that the approach is exactly perpendicular to the pedicule you're taking. This applies for the round ligaments and the uterines, as you see later on. Because this is a smaller uterus and because I'm a little more medial with my right hand port, I can afford to cut with the scissor here. You may not be able to in larger uteri or different pathology, so then your assistant has to alternate, or you can use what I learned during my fellowship at Changan, where you give the assistant 2 ports as well. So there's coming to the next step after you finish sectioning the round ligament here. So we cut just the anterior peritoneum. You're not going to sit and dissect the bladder here. This case I chose was to show a previous cesarean section. Now this is important where the assistant holds the bladder and the peritoneum and lifts, because the bladder is free in the midline. So even if you're cutting across where it's fixed to the pillars, it might be coming under your instrument in the midline. So I just cut round ligament to round ligament from here, while the vaginal assistant is swinging that uterus across to make my access easier. Here, the trick is to hug the ovaries. I do my salpingectomy or my adnexectomy at the end because I don't like the ovaries hanging in the way. I don't like to use a 30-degree scope because it requires a lot of manipulation with the other hand. Unless, of course, there's a very large anterior fibroid which is not allowing me access to my bladder without an angulated scope. So, the trick here is to hug the ovaries. Again, don't run too close to the uterus. You're going to get a lot of back bleeding there, which just looks untidy, and it also absorbs color of the scope if you're using an inferior scope. So now this puts the broad ligament at a stretch. I have an interesting technique which I will demonstrate on the other side in a moment. So again, continuing, the assistant is using the bipolar to selectively coagulate. You don't need to continuously coagulate into blood, and the important trick to keep your bipolar clean is to step off the pedal before you open your jaw. to open the jaws before you step off the pedal. So that hole that's made once you stretch parallel, this is where you aim for, because the ureter is on the lateral border of this window. So all your dissection has to be medial to this, and you'll never run into the ureter while you're jumping down here till you dissect your bladder away. So again, you can see some fibrosis from the scar. So this right tubo-ovarian structure is very easily accessible to my right hand, and as you can see, I'm aiming for that hole down there. So it's quite joining the dots. Here you can see it's not really ergonomically correct as I proceed, but I'm kind of getting away with it. And you can see there's only been 3 of these instruments for this part of the case so far. And the same thing, I still coagulate close to the uterus, but I will cut closer to the ovary, just to take care of any retrograde bleeding. So now I realize that this is more optimally approachable with my right hand, so I have to alternate here. This is a bit time consuming. Maybe a multifunctional instrument is beneficial here, but it doesn't take that much time. So there's no need to rush through these steps. If you cut more than you coagulate, you're going to have a bleeding which retracts, and you're going to waste even more time suctioning and catching that bleeder. So prudency is key. Now, coming through the bladder dissection, once you've cut the peritoneum, you will approach what you do with vaginal hysterectomy as described by Professor Shirishé, and you can appreciate it better, which is right above the uterine. You can open and you see the pearly white cervical tissue, and the adhesions are highest in the midline. So I alternatively undermine with the bipolar, give it a short burst to not allow the bleeding. And my vaginal assistant is retroverting and pushing very far T-falad. So this is giving me traction and counter-traction to do my dissection. As you swing across from lateral pillar to the lateral pillar, and use the blunt end of the bipolar to push the tissue away. So you can see Dilly's fascia, which is just by producing the traction, and the carbon dioxide creates your plane for you, and you can push it down bluntly or just make a small cut towards the uterine end. Catch all the residual capillaries that have decided to announce themselves over here. And I do quite a bit of dissection down, so I have, even when I close, I have a good vaginal cuff to close. I will open the vagina somewhere here, but I still have a good cuff to close with. So you push all those fibers down till you're comfortable, and then you're ready to take your uterines off. There's no need to skeletonize the uterine, but you have to take it in a couple of sections, line the wall of the uterus, and again, selectively cut very slowly. If you cut slowly and you see blood announcing itself, immediately you come in with your bipolar, and you can see the uterine there and the tortuosity of the vessel below. So you might have to deal with it along several planes, and beware of the veins. So we all tend to pay a lot of attention to the artery, but we will push in and nick the vein quite often. So that's something to watch out for. So you usually don't want to allow the venous bleed here because the vein will retract, and when you chase it down is usually when the urethra gets injured. So you've got to watch out for that. As you can see on the other side, the co-surgeon takes it and the incision, is made. Here, this is very interesting to show because this is where I make a mistake. In the effort to save time, you cut across the area that's coagulated. So you're going to cause a little bit of retraction. So I thought this was important to show why you should optimally approach perpendicular and not take shortcuts. I always say laparoscopy is a very cruel mistress. If you make one mistake, you have to do 10 things to correct that mistake. But luckily I got away with it here because we caught it in time, so there's not much bleeding, as you will see in 1 second. So you see the scissors are coming across below the fundus, and that makes the vein below the artery. But we caught it quickly, so no harm done. But I thought it was important to highlight this. So there's no need to dissect the posterior peritoneum too much. I try not to cut into the uterosacral. Sometimes you may have to. So I cut where the uterosacrals insert into the torus of the uterus. So now is when the cup is introduced. I don't introduce it during the beginning of the case. After the bladder is dissected down, this is when we introduce the cup. And the fundus is being pushed kephalat, the cervix is being pushed by the tenaculum grasper of the uterine manipulator, and the cup is on full stretch to try and conserve as much of the vagina as possible. These are women who are it's a benign hysterectomy. You don't want to do any radical procedure by taking off vaginal tissue. So you try to save as much of vagina as possible. So the previous speaker mentioned that there's dehiscence, so it depends on what energy source you use. Of course, the best energy is no energy, but we don't like bleeding in laparoscopy, so the next best thing is a monopolar or a pure cut. I believe the harmonic is better, but I'm not going to open a harmonic just to do a colpotomy. So the next best thing would be a pure cutting monopolar current, which, if you use correctly and quickly, is going to be akin to almost a cold blade. So this is going to reduce your chance of dehiscence, and you don't need to cut it in one fell swoop. You need to cut it in layers, especially if there's a thickened vagina. And once your vaginal assistant is giving you direction by presenting it, the co-surgeon will take over on the right side, and I like to do the posterior part last because the uterus is well held, so it's not going to slip. There is a valve which is preventing my pneumo from being lost, and you can see the posterior is very important, that we're not cutting the uterosacral, so we're preserving the peristallical ring. This is going to prevent dehiscence of your vault and not give you vault prolapse in future. So there are many small steps that enable you to do a procedure perfectly without complications. And how do we remove the uterus? There's many ways. As far as we are concerned, vaginally is the best way. And this is something I learned in Changon during my fellowship, which is very invaluable for larger uteri. I and for fibroids. I don't power morcellate personally. Preferentially, I have nothing against it. It's always a good thing to do if you know how to and if it's available to you, and some places you may not get a wound retractor. So there's no harm in morcellating. I don't agree with contained morcellation. Maybe if you have a suspected malignancy, you're going to remove it vaginally, and for hysterectomy especially. For fibroids, it's another story. I believe if you've enucleated a fibroid, which is a cancer, you've already upstaged, so it's a little too late. So coming down to vaginal closure, I suture with my left hand for the left angle, because the needle holder should be parallel to the incision. The vagina is very forgiving, so you could probably get away with suturing with your right hand. I still will take my lower angle through the uterosacral as an added measure of support. And so this one was not a very thick vagina. I will do a single layer closure on this one, provided you take full thickness. I will reperitonize at the end, so that's my second layer. Not as extensively as Masaki Ando showed yesterday. I'm just over the raw area. I don't go round ligament to round ligament. But that's a good technique if you have the time. So maybe a figure of 8 at the left angle. Then I will cut it and continue from the right side. So the assistant is important. Anyway, you can use multifilament or monofilament here. So I use a toothed needle holder from Storz. This one was developed, but I've stopped using this one because we broke the tooth of 2 of them, and it was quite nerve-wracking to find them. So now we use a different company's needle holders, which is a sturdier tooth. But it's very good for grasping the vaginal cuff, so you can get your full thickness closure. So then we cut this end, and then I will begin from the right angle. So this one I like to take with my right hand because the curve of the needle goes perfectly through 5 o'clock and 2 o'clock of the angle. Still take the uterosacral, and now you see with the right hand you can just swing it through. And it's important for the angles to get a full thickness. You don't need to go too lateral and include the uterine pedicle, because if you coagulate it properly, and if you try to take the uterine there, there are very high chances of catching your urethra in that angle. So you should be hemostatic. It's important not to, you have a healthy oozing at the vault, so don't go and camp on the vault with your bipolar, because then you're creating necrosis and ischemia there, which is not going to heal, and it's going to cause big problems. Yeah. So once you get that angle, then I switch back to my left hand so I can watch the needle come through in its full thickness here. So this is wrong, this is not full thickness. And then I will go through and take this. So if you've got a very thick vagina and you're using a smaller needle, you will take 2 layers. So there's no point, there's no need to try and do it all in one swoop. So you can use 2 layers, there's nothing wrong with it. Right,
Excuse
so
me,
yeah.
we have to stop.
Okay, last slide. So the last step is hemostasis. See, I said I do close my peritoneal cuff. I've done a salpingectomy and removed it through the ports. There's a little bit of endo at the end, which I excise, but that is not for here. And just a final take-home message is learn to use both your hands, and this is how you should train your juniors and your fellows. And hemostasis should be meticulous to enable you to be fast and efficient, and use minimal instrumentation that will save you time. Thank you.
Thank you very much. Thank you for your participation.